I've seen foot drop on my YouTube channel. You can look at it and watch the video of somebody with foot drop to no foot drop in like a minute and a half when I open up their SI joints. I was able to get this patient out of pain and confirm with not a shadow of a doubt that she did not have sciatica in her leg. With that, if you want to learn more, you can do my Rehab results course, which is my orthopedic protocols, okay? Where I go much more in depth into a lot of these issues. And then I have my F-bomb method that people call. People can't believe that their pain's gone instantly, so therapists tell me they call it the F-bomb method. Yo, everybody, what's up? Physical therapist, Dr. Ryan Whelton, coming to you live from just outside the beautiful Tampa Bay area. If you're new to following me, I have a clinic where most people have kind of failed everything type of clinic, and I get exceptional results within that population. I develop protocols that people have been cutting and pasting all over the world for years. And through my online courses at wheltonmethods.com, and get people out of pain immediately and relieve and fix people by addressing root causes of published papers in peer-reviewed journals that can be found on my website, wheltonmethods.com. Okay. I'm also now on Spotify, I am on Apple Podcasts, and I'm on YouTube in long form, where I teach this stuff live. Okay, so the thing that I talk about all the time is SI joint dysfunction, sacral torsion, sacral shear. So today I had a patient who came in, has had pain for 23 years, and marked off on the chart, like this. Right in here is where the pain was. So, if someone has had pain for 23 years and they mark off low back, leg type area, I knew what she had before I even touched her or talked to her. And the reason why is because if you do my SI joint protocol that I published, in my evaluation method, my diagnostic method, and I go much more in depth on YouTube into how to diagnose it. But if you use that evaluation method, you will be shocked at the amount of people that have failed everything, and then you open up their SI joints and you see referred pain patterns that are not documented that I know, including in the groin area, testicular pain, all the way up to the to the thoracic spine, into the foot, causing every symptom that neurological issues cause. Okay, including weakness. I've seen foot drop on my YouTube channel. You can look at it and watch the video of somebody with foot drop to no foot drop in like a minute and a half when I open up their SI joints. Okay. All right, so today I rehabbed. I have my evaluation. I evaluated someone today who has had pain for 23 years in their back and buttock and posterior thigh and anterior thigh. Has had PRP injections recently, radio frequency ablations. They burnt the nerve. Okay, that did not help. Had a laminectomy. That made it worse, and the operative report says that they did a laminectomy, they removal of disc herniation, and placement of epidural steroid. And she said it helped a little bit with my left leg, but she's like, but made this worse, and my right side, and I can't sit, I can't stand up, I get stuck, it's horrible pain, the typical SI joint story. Can't sit on certain surfaces, can't roll over in bed, getting up in the morning. Similar to arthritis patients, getting up in the morning, they will tell you that this is a common issue? Well, they get going because they're locked down, and then they get going and it eases up. So with this particular patient, my next question out of my mouth to every SI joint or every postoperative patient that shows up here without relief, and I said, what did the surgeon say? And they said that, yeah, no, it was basically a success from the surgeon standpoint, but, you know, you got arthritis. I mean, this person was in their 50s. You got arthritis, so, you know, why don't you go to pain management, right? And she said, I just refuse, you know? She's like this, she said, it's my hip. She actually said that to the doctor. It's my hip. I find that patients always know. They always know. If you just, I value a patient's word actually over a medical provider's word about what's going on with their body. You know, like if your pelvis is out of alignment, you can feel it. So like usual, this person said to her doctor, my hip, it's my hip. And he said, there's nothing wrong with your hip. But what she was trying to articulate is actually her pelvis, not her hip joint, her pelvis. I'm sure that he looked at her hip, but her pelvis was out of alignment. So I was so confident that I knew what was wrong before even touching her, is that her husband was here, and I just had her turn, face this way, and I told her husband, I said, watch this. And I put him right behind me, and I said, I put my thumbs on bilateral PSIS right here, and I asked her to extend back. And when she extended back, my left thumb, on her, my right thumb translated superiorly, okay? And that told me that she had an upslip on the right side. She had SI joint dysfunction, right? So I pulled on her, so I took her out and I pulled on her leg, okay? And brought that back down into alignment. And then I read my paper, SI joint dysfunction, outlined in the paper, caused by an upslip and or out flare. In the chronic pain world, they usually have both. And I laid her on her side, and I was gapping open the out flare, okay? And I had her stand up, arch back, the aggravating motion. She still had pain, okay? It was better. She could go farther, but still had pain. So then I had her squeeze a ball. Why? Because standing adduction continually opens the out flare, and I made sure that both of my thumbs, it wasn't the upslip anymore because both of my thumbs translated inferiorly, not one went up superiorly. So I knew it wasn't that. So I did the gapping with the out flare gapping with the standing ball squeeze. And she said it came out of my leg when I did that, and then she said, in my left pain that she was pointing actually to her SI on the left side, excuse me, she said the pain on my left side of my back is gone, but my right side is still hurting right on the SI area, she was saying. So I got on, so with the ball squeeze, I got on one knee and I went like this. Like that, and I opened it, I held it open, and I said, now arch back. And when she did, she says, I don't have any pain anymore. I said, no back pain anymore, no. No buttock pain anymore, no. No thigh pain anymore, no. Okay? And I said, that's that, okay? Now, like usual, she had a sacral torsion, so when I first evaluated her, I do this in standing. Some people said they can't. I published it. You can read my sacral paper. I published it. New evaluation method, much easier evaluation method. But chronic SI almost always comes with sacral dysfunctions, I find. Okay, so I had her bend forward like this, and my left thumb translated anteriorly. Okay, dipped in. So that told me she had sacral torsion. Okay, so while she was on my mat, read my paper or take my Rehab results course online. I go over this much more in depth than that, and I was pushing like this that angle like that. So that would be anterior and inferiorly. And I was rotating her sacrum back. Okay? Now, that can cause pain at the base of the spine. I found it can cause pain that translates superior and cause an achiness across the back, okay? And buttock pain, which she had. When I rotated that back, boom, that was gone too at the base of the spine. So that's called the sacral shear, okay? So I was able to get this patient out of pain and confirm with not a shadow of a doubt that she did not have sciatica in her leg. What she had was SI joint referred pain, okay? I do this all week long. As people come to me with these MRIs, I got one guy right now who has a very severe MRI, severe herniations on every level. He literally took him a minute to get off my mat. I mean, this guy, I felt bad for the guy. I mean, I was actually telling him the other day, I said, most people say they're a 10 out of 10. I'm like, but they're not because they'd be in the emergency room. I'm like, I would have called what I met you a 10 out of 10. This guy was shaking. He had to sleep sitting up. Anyways, when I opened up his SI joints on his evaluation, his pain was gone instantly. And I was like, yeah, no. I'm like, this is SI joint. This isn't, you have herniations, but I didn't touch your spine today. Rotated his sacrum back, boom, all of his pain was gone. Anyways, we started doing the rehab. He couldn't get off my table for the first couple of visits. It would take him a while to get up because he was in so much pain. And he comes in here and he's swinging his hips while he's walking, and he hopped off my table last time and he's doing so much better. I think we're about 3-4 weeks into it. So this poor guy was struggling, and they're not just in Tampa, they're everywhere. I'm telling you, it's crazy. All my students have been telling me for a long time that they've been seeing, or like their clinics explode from low back pain. I've had people in Nigeria, therapists in Nigeria say, like they see this all the time now. Once you start helping people with low back pain that nobody can figure out, which is usually SI, sacral torsion shear, I find, then your clinic just turns into something else, okay? So anyways, that was a story with this patient. I expect her to get better in about 5 to 8 weeks-ish. My average student tells me, using my SI protocol, that it takes them about 4 months to get a chronic SI joint patient better-ish, 4 months-ish. I'm an inventor. I figured out how to strengthen people. And anyways, I figured out how to do 9 out of 10 or more in about 5 to 8 weeks. And then I always say that 1 out of 10, I warn the patients up front. 1 out of 10, I call them long haul SI rehabs. They take longer, okay? And they take months and months and months and months. They usually get to a point 50, 70, 80% better, and then boom, their groin muscles just can't strengthen. And that's what I call long haul SI rehab. And they have to go up really high in weight on their groin muscles to get it open. And it's like a monumental task for these people. If I could figure out how to do it, it's like the bane of my existence in terms of rehab. I generally don't have trouble in rehab, but these people will give you a run for your money because they can't strengthen their groin muscles no matter what. I've actually had PTs in here that are like, I know for what I do for a living that I should be able to strengthen my groin muscle, but and then I test it and you can just break them, an adduction, a side lying adduction, and they've been doing the strengthening exercises for like 3 months. Those are long haul SI rehabs. And they just have to go up and weight, but you have to watch out for their knees, so don't put too much. I usually say don't go over 20 pounds to my patients on your ankle, because you'll hurt your knee and start putting it above that. It's crazy, but it's anyways, it's pretty, but if you don't help them, then a lot of times these people end up in this craziness that I talked about today with failed surgeries and injections and nerve cutting, and it wasn't even the problem. So anyways, let me grab, Ina, can you come here for a second? All right, stand here. Everybody know Annette, Vanaway Physical Therapy, who has been a model for physical therapists for almost a decade now, Annette. Congratulations. Stand here, face that way for me. Okay, so when I evaluated this patient today who had RFAs, disc removal, laminectomies, and steroid injections and PRP, basically to no avail, and she still had pain here and then all down her leg, basically to about here. Okay, I put both of my thumbs on the PSIS to palpate the PSIS. People struggle to do this when I taught live. To palpate the PSIS, put your thumb, and you're looking for a knob that your thumb just kind of goes over, like just falls on and off of, okay? Both sides. And then I said, go ahead and arch back for me, please. And then in her case, my right thumb translated superiorly, which told me she had an upslip of the pelvis, okay? That's why it's translating superiorly, is because it is locked like that. So so it's going up, not down with the sacrum. So if it was aligned with the sacrum, it would just go down like the other side, okay? So this is what I did with that, is lay on your back facing up for me, please. Okay, so I asked her, have you ever had any hip surgeries? Never pull on a leg without asking them that. If you pull on a total hip replacement or hip surgery, then you dislocate that, the person's going right to the emergency room, and that's on you, okay? So I say, have you ever had any hip surgeries? No. So I say, I'm gonna pull on your leg, doesn't hurt, a little bit of a tug. And I protect my back. I don't go like this because you're gonna hurt your back, okay? So what I do is I grip underneath the hamstring. I don't like to pull down here because you can hurt the knee. So I grip under the hamstring and I pull like that. And I want her to slide on the mat. And you may need to do it a few times, and you'll know it because you'll check your test and extension to see if your thumb still translates superiorly. So I said, go ahead and stand up for me, please. And in this patient's case, arch back for me, please. Both of my thumbs were now translating inferiorly, okay? So I knew I got the upslip with her, okay? But it's caused by an upslip and or outflare, I find, in the chronic pain world. So go ahead and lay on your side face this way for me, please. So then I laid her on her side, and I usually take a hydroc pad, and I was pushing medial on her ASIS, okay, like this, and you can feel it spring and move. You can put your other hand on the SI joint and you'll feel it gap. So I went like this for about 20, 30 seconds, and then I had her on both sides, and then I had her stand up. And I said, go ahead and arch back. And I said, do you still have that pain? And she said, yeah, she was able to go back further. So then I put a ball between her knees and I say, squeeze, feet together. That's key, feet together, okay? Because you can't squeeze as hard with your feet together. And what I'm doing is firing the adductor group and further gapping open the outflares, okay? Once you've got the upslip, it's the outflares, okay? So I said squeeze, and I say now arch back. And she said that, yeah, no, it's out of my leg. It's out of this side over here, the left side, left SI, but she still felt it here. So what I did was I got down and I started pushing medial on her ASIS while she was squeezing a ball, okay? And when I did that and had her extend back simultaneously, what I was doing is further opening the SI joint, okay? And when I did, she said, boom, my pain's gone everywhere. And then I say, okay, I got it. I confirmed what's wrong. And now we need to put her on my SI protocol, and her sacrum was out of alignment. So we're strengthening the right piriformis muscle with her, and I expect her to be better at the end of this, despite 23 years of pain and all this that she's tried in terms of failing everything. Thank you, Annette. So when it comes to chronic SI, okay, when it comes to chronic SI and sacral dysfunctions, you basically know what it is at this point in history. If they failed everything and they got this back pain, hip pain that nobody can figure out, it's almost always that. Okay, so just check for it, okay, and then use my evaluation method that I published for free for sacral dysfunctions and for SI, and you should be able to diagnose it and then work with the patient and make sure you warn them. One of the most important things about it is actually to warn them how long this takes, okay? Nobody wants to do exercises for a month and a half and not notice a difference sometimes. You know, I mean, like, if you told me to do exercise for a month and I still didn't notice it, I think this person's crazy, you know? But if you warn them that this is going to take that long, then you managing expectations. That's what I've learned from 20 years of treating patients. If you manage expectations, then then they're with you on it, okay, generally. But and then also you warn them that this is going to be an up and down process, okay? Healing is not a linear process. Rarely, extraordinarily rarely, someone just gets better, okay? In fact, it happened to one lady years ago, and I told her, do not ever tell anybody that after 20 years of pain, you came to me once and your pain went away. And she was like, what? And I was like, don't ever tell anybody that happened here. And I said, I don't want people getting the wrong idea of what this is, okay? That if you want lasting changes and move your pelvis back into alignment from being out of alignment, that takes an extraordinary amount of strength, okay? So, and a lot of work. So if you want lasting changes, a lot of work, okay? You need to warn them that it's an up and down process, okay? And that's that with that. If you want to learn more, you can do my Rehab results course, which is my orthopedic protocols, okay? Where I go much more in depth into a lot of these issues. And then I have my F-bomb method that people call. People can't believe that their pain's gone instantly. So therapists tell me they call it the F-bomb method, the patients. And then my sciatica cervical redic course, which is sometimes an F-bomb method, meaning that, for me, I stimulate these points, boom. Majority of people, their sciatica cervical redic goes away. And I would say, in my clinical practice, I even have a pain management doctor now doing it. Good for him. Good for him. And that is going away. So he's getting great results, he said, with it. So, and then I have my membership. And then I also have, my inner circle where I share like new things that I'm developing and coming up with much more in depth into these things. And then I also have, what else do I have? I have my cash-based business model. So everywhere I went in the country, when I taught live, people used to ask me, will you help me open and run one of those clinics? For years I said no, and then I said, okay, I'll do it. So I started doing that and helping people. So I am going to be teaching in a community now, where people for years have emailed me, asked me questions about their patients. And for years I had said no. I said no to teaching live, but now I'm going to do it on Zoom, and we're going to create a community where there's Q&A and it's interactive, and you can ask me questions, and I can see what you're up to, and then also people can bring in their patients, and we can all learn together, and I can help guide the diagnosis and treatment plan. So it should be really cool. My goal is to get people diagnosing these things and helping these people, especially these chronic pain patients that have tried everything type thing, okay? Anyways, that's that. Give that, please share my papers on my website, wheltonmethods.com. Give my protocols and help people, because that's the goal in this world. Peace, love you all.